In this presentation, we're going to cover the EKG changes, specifically the electrical changes that occur on the heart monitor, specifically with regards to ischemia and infarctions. What I'd like to do first is I'd like to explain the progression of ischemia to infarction. Whenever a blood clot blocks a coronary artery and blood flow is either completely stopped to an entire area of the heart or it is reduced significantly to an area of the heart, first you have the injury. If it continues, then you start developing some ischemia, and then if it continues to develop, eventually you could very easily lead into an infarction issue. So the two areas that we're going to explore first are transmural and subendocardial. Now, when I say transmural, what this means is this involves the entire thickness of the heart wall. That's what the word transmural actually means. Subendocardial, of course, is just the very innermost part of the wall, and we'll talk a little bit more about that later. The first thing we're going to discuss is transmural, because this is the one that is very easy to identify on a 12 lead, and it's much more deadly, of course, because it's involving the ischemia or infarction is involving the entire thickness of the heart wall, from the subendocardial layer all the way out to the epicardial layer. First of all, I have a question. In many of the classes that I teach this information, the first thing I like to ask my students is, how many of you have heard in the past that STsegment depression over here is ischemia and STsegment elevation is infarction? I used to be very surprised that a majority of the students raised their hand and said, oh, that's what we heard, that's what it must be. Nowadays, when I still ask that question, I still get a lot of students, but I'm not surprised anymore. For some reason, that philosophy or that educational gem of depression is ischemia and elevation is infarction has been perpetuated. Well, I'm here to tell you right now that is 100% false. Depression is not ischemia, and elevation is not specific to infarction. And hopefully after I explain all of this, it'll make a little bit more sense. So let's go ahead and start with the transmural effects. Like I said, transmural refers to the entire thickness of the wall. If you look over here, it says that it's in the shape of a wedge. As you can see here, it goes out this way and out this way. There's a reason for that, and a lot of people say, oh, well, it's because of the curvature of the myocardium. That's not entirely accurate. What happens is the surface coronary arteries, as they go into the endocardium or head down into the endocardium, they branch off with collateral circulation. So if an artery over here is being affected, what happens is, as it goes down, yes, all of this is going to be affected here, but this artery over here is going to have collateral circulation that's still going to provide a little bit of circulation the further in you go. That's just nice to know information. Let's start talking about the stages of transmural ischemia, which will eventually lead to infarction. There are 5 or 6 of these general phases, and you could progress through them, or a patient could progress through them very quickly, or it could take a couple days. It kind of depends on how large the clot or how large the occlusion is in the coronary artery. The first phase that somebody may exhibit is something called the hyperacute phase. This hyperacute phase will have a symmetric and somewhat peaked T wave. Now, one thing to remember about these T waves is a normal T wave is not supposed to be symmetric. If you remember, T waves are supposed to have a very gentle upslope and then maybe a sharper downslope, where if you were to draw a line down the middle, you would have these lines going this way, but those lines would be traveling straight down. This is a good T wave. This would be a bad T wave because it is peaked and a little bit symmetric. Now notice that there is no ST segment elevation yet, and yet the person is in a hyperacute phase, which means this person is having some ischemia. This person is having a heart attack, but this can very easily be missed on the monitor. The next phase that we head into is a phase that very commonly we see and we go, oh my goodness, this person's having a heart attack. So as the ischemia continues, the ST segment, this little part right here, will start to go up from baseline. If the ST segment elevation is greater than 1 millimeter above baseline, in 2 or more contiguous leads, then you can consider possible ischemia. In this case, it's pretty obvious that this is probably 3 millimeters. So if you look at from here to here is 5, that's about 3. So it looks like there's about 3 millimeters of elevation there. So I'd definitely say that this person is having a heart attack now. So the first phase was a hyperacute phase. If you have ST segment elevation, it is now the acute phase. So we progressed from hyperacute to acute. The next phase that you're going to see is the evolving phase. Now the evolving phase, what will happen is your T wave, which was going up this way, has now everted. But look at this, we still have our ST segment elevation. This could occur hours to days after the acute phase. It may not occur at all. We may not see this at this point in time. But the point is that for the evolving phase, the T wave will evert or invert with ST segment elevation. That is the acute phase. One thing to remember is that up to this point, technically this is all ischemia. No infarction has actually occurred yet. If infarction does occur, then you will have something called fully evolved. What do we mean by fully evolved? What that means is there is a pathological Q wave right here. If I back it up one slide, you will see this is your Q wave right here. This is a nice, cute, petite little Q wave. It is not very large. It is the perfect size. If we look at the next phase, which is the fully evolved phase, this is a huge Q wave, much larger than it's supposed to be. Now, pathological Q waves, it kind of depends on the text you read. Pathological Q waves are greater than 0.04 second, and they have to be at least 1/3 the height of the R wave. And I'll show you how to calculate that later. This right here is definitely, at minimum, a 1/3 the height of the R wave. At this point, we truly have myocardial infarction. This is a true STEMI. If you look at the previous EKGs or the previous QRSs that I was showing you, what you will have is you will have a cute petite little Q wave and the QRS and then the T wave. It's kind of hard to draw that. This right here tells me that it is ischemic. This tells me that it's infarcted. This is not uncommonly called a STEMI. Sometimes people will see this, and even though this is technically still in ischemia, this will still be called a STEMI. When you get down to it, it doesn't really matter. The person's having a heart attack, he needs to be treated, or she needs to be treated. Don't quibble over the fact that, oh, well, it's not a true STEMI until you have pathological Q waves. Either way. Now, I also put up here a Q wave MI. This is what they used to be called because you had a pathological Q wave. It was called a Q wave MI. We also had non-Q wave MIs, but we can't really determine that unless there's actual blood values. So Q wave MI and STEMI are pretty much the same thing. They're the exact same thing, it's just different terms. What happens if the person actually survives the heart attack? If the person does survive the heart attack and you have a person who has a healed heart, as it were, relatively speaking, there is always going to be evidence of a pathological Q wave. I'm going to back it up one slide here. If the person gets to the point where they have a pathological Q wave, they will now always have a pathological Q wave. This is the healed phase. If the person never has the infarction process occur, if we can intervene in time and restore blood flow to the myocardium before it infarcts, then the person will not have a pathological Q wave. But if the person does have infarction, there will always be a pathological Q wave in one or more leads. This is called the healed phase. So just as a brief overview here, if you look at the first phase all the way over here, here's number 1. This is the hyperacute. Number 2 over here, this is the acute phase. This is number 3. This is the evolving phase. Because the T wave has inverted, now it is becoming an MI or an infarction. This is the 4th phase. Because you have your pathological Q wave here, this is now fully evolved. If the person survives, then this is considered the healed phase. But notice there's always going to be a little pathological Q wave. We're going to discuss lead localization now. You have to understand the lead localization with the ST segment elevation to know where this is occurring in the heart. I did cover this quite extensively in my first presentation, the introduction to the EKG, where I talked about what each lead looks at. That's a great review if you need to. This is just going to be a real short, sweet review of what each lead looks at. So first we're going to look at the left lateral lead. Left lateral, you're going to look at leads 1, AVL, V5, and V6. If somebody's having ST elevation in 1 AVL, V5, or V6, any one of these leads, or 2 or more of these leads actually, then somebody is having a problem, as you can see over here on the left side or the left lateral wall of the heart. If somebody is having an inferior problem, then you're going to have problems in the 2, 3, and AVF. So if you have ST segment elevation in 2, 3, and AVF, then you know you're having an inferior wall MI, which is actually going to be down here. If you want to see the interventricular septum, you look right here in 1, V1, and V2. If you have ST segment elevation in V1 or V2, it's considered a septal MI, which right there is the interventricular septum. If the patient is having a problem with the anterior left ventricle, remember this is not just the anterior aspect of the heart, it is the anterior left ventricle. These are the only 2 leads that are really separated. Everything else, as you can see, the laterals, the inferior, the septal, they're all kind of bunched together. These are the only 2 that are separated a little bit. But if you want to see if the person is having a heart attack in the anterior left ventricle, you look at V3 and V4. And finally, in the precordial leads, V5 and V6 are also considered left lateral. Hopefully that was a bit of review. If that didn't make much sense, please go back to the first presentation I put up, Introduction to the 12 lead, and I'll explain it. It explains it very well in there. you need to have an understanding of where each one of those leads are located on the piece of paper, as well as what they look at on the heart to understand what part of the heart is being affected. So let's go ahead and practice a few real quick. I'm not going to go through the 6-step interpretational process quite yet because I just want to practice lead localization. Where exactly are we having the problems? Now, if you look at this one really fast here, what do I say before? We want to look at STsegment elevation. There's elevation, lead 1, AVL. It looks like we might have some elevation here in V1. We definitely have it in V2 for sure. V3, V4, V5, and this might be considered elevation. We're not really sure, but it could also be a V6. So if you remember this little picture right here, in 1 we have our lateral, AVL is lateral, V1 is septal, V2 is septal, and anterior, V3 is anterior, V4 is anterior, and it could look a little bit lateral. V5 is left lateral, and V6, left is lateral. So these are the areas that we're having a problem right now. Lead 1 and AVL, V1 virtually through V6. The next question is, how do you document something like this? How do you document that the person is having all of this stuff going on? It kind of depends. I've read a couple different things. You're supposed to do it alphabetically, or you do it by the most elevation somewhere. I haven't found it. If anyone finds out the real answer, please let me know so I can make sure I put that out in information. But what you can say is that since this person is having an anterolateral wall MI, you can say this person is having anterior lateral wall MI with septal extension or septal involvement. Would be a pretty good interpretation there. My next question I have is, has this person had a heart attack yet, had a true MI, myocardial infarction yet, or is this all still ischemia? And regrettably, this right here looks like a pathological Q wave. That right there looks like a pathological Q wave. So it is possible that this person is currently having a true heart attack and not just ischemic tissue. This one is a little bit more subtle, not quite as in-your-face kind of thing. If we look for our STsegment elevation, we have it here, here, and here. So, and if we look down here at our picture, 2, 3, and AVF are all inferior, the inferior leads. So this person is having an inferior wall MI. Now, is that the only place that the person is having any kind of STsegment elevation? If we look over here, this might look a little bit elevated. That might look a little bit elevated as well. I'd have to get out my little piece of paper or a straight edge and see, but it looks like that there might be a little bit of lateral involvement as well. So V5 is lateral or left lateral, V6 is left lateral. So this person might be having an inferior wall MI with lateral extension, which tells me, if I were to draw a heart here real quick, this area is definitely being affected, and it looks like this area also might be affected as well. So this possibly is an inferior lateral wall MI occurring right now. Here's another one, a little bit more obvious. Where's our elevation? 2, 3, and AVF. 2, 3, and AVF are inferior, inferior, and inferior. And then There doesn't seem to be, oh, there is a little bit more elevation. This might be elevated here. It's kind of tough to tell on this one. That one might be elevated. That looks elevated, and that looks elevated. So here we possibly have another inferior wall MI, which is, this is an acceptable abbreviation, with lateral involvement or lateral extension, or it might even be anterolateral, which you could also say anterolateral wall extension. One more here. It looks like that we have another one that has some inferior involvement. It looks like lead 2, 3, and AVF all have involvement. 2 is inferior, 3 is inferior, AVF is inferior. Whoops, supposed to be an I. It looks like that everywhere else is ST-segment depression, which would be a reciprocal change, and we're going to talk about that a little bit. V6 might look a little bit elevated rather than depressed, and maybe V5. Kind of hard to tell. There's definite T-wave inversion right there, though, which tells me that there is some ischemia going on in the lateral area. So we could definitely say that this is an inferior wall MI. Now let's talk about some subendocardial ischemia. I want to talk about the electrocardiographic changes that are going to occur with subendocardial ischemia. First of all, where does subendocardial ischemia come from? First of all, if you remember this picture over here on the left from the previous presentation, if you remember this picture right here, as you have this cap right here, this collagenous fibrous cap right here, if it ruptures, it's going to start exposing collagen to the bloodstream. If it starts exposing collagen to the bloodstream, you're going to start the clotting cascade. When you start the clotting cascade, initially the clot has to develop platelet aggregation, then it has to develop a platelet plug before it starts actually developing the clot itself. During the platelet aggregation and the platelet plug phase, this clot is very unstable. Before it can really build those fibrin threads, the clot is still unstable. So what happens is you have these little bitty pieces of the clot or of the unstable clot that tend to break off and start traveling downstream. During this time, these little clots right here will make their way into the subendocardial area. If you look right here on the picture on your right, it makes their way down here into the smaller capillaries, and then they get stuck. This is considered subendocardial ischemia. This process that occurs right here has a specific name. It's called microembolization. This microembolization causes subendocardial ischemia. Now, as this clot continues to build, it will become more sturdy, and eventually it may actually build up to a point where it does occlude this entire coronary artery. You no longer have this microembolization. What's going to happen is your subendocardial ischemia is eventually going to make its way across to transmural ischemia as the clot gets bigger. But a lot of times in the initial stages of this process, subendocardial ischemia is present. How do we determine subendocardial ischemia on the EKG? Well, a lot of times it is seen as ST-segment depression. There's a lot of times where we see ST-segment depression on the monitor and people blow it off because it's not ST-segment elevation. Oh, they're fine. Monitor doesn't show any ST-segment elevation. If there's depression, there could be a heart attack going on. Unfortunately, not all ST-segment depression is considered subendocardial ischemia. There are 3 kinds of ST-segment depression. The first ST-segment depression is going to be considered an ST-segment depression with a negative deflection. Now, when I say negative deflection, we're going to look at the J point right here, and we're going to travel in a straight line downwards. That is considered a negative deflection. If your ST-segment has a negative deflection, that is most indicative of subendocardial. Ischemia. Most indicative of subendocardial ischemia is an ST segment that has a downward deflection. Another type of ST segment depression is going to be the one where it is squared off, or there's no deflection or squared off. This is actually considered horizontal. This is moderately indicative of subendocardial ischemia. It is still indicative of it. You still need to treat the person as if they're having a heart attack. But as you can see here from the J point right here, it is completely squared off. The third type of ST segment depression is one that actually has a positive deflection. This is, if you look at the J point right here, as it travels back up to baseline in this direction. This is the most likely causes from other causes is what it is. Least indicative of subendocardial ischemia. In other words, if you see this, not very diagnostic. You can't use this at all. On the other hand, please remember, irregardless of what the 12 lead tells you, you still need to treat the symptom. If the patient is experiencing symptoms of an acute coronary syndrome, it doesn't matter what direction the ST segment is traveling, you still need to treat the symptoms of the patient. I love this 12 lead. So find the ST segment depression. First of all, do you see any elevation? We don't see any elevation, but we see quite a bit of ST segment depression. This might be difficult because my little ink doesn't show up very well on the 12 lead. So I'm going to try to do this very carefully. So let's look over on lead 1. Do we have any ST segment depression? We do. It looks like we might have a little bit here. We have a depression here. AVL, we have trouble saying F. Maybe not. Looks like we have a lot of ST segment depression here. Maybe a little bit, yeah. And then, holy moly, we definitely have it here in V4, definitely have it in V5, and it looks like we might even have it in V6. Now, where is the subendocardial ischemia occurring right now? If you look at it, it looks like it is occurring in well, maybe not V1, V2, V3, V4, V5, V6, and maybe even one in AVL, because AVL has a very flat ST segment, so, and a flat T wave, so that could be considered ischemia as well. So this person is having microembolization in the anterior lateral leads. Unfortunately, this is the pitfall for not walking through your 6-step process. Until you get really good at interpreting these 12 leads, you really have to walk through your 6-step process. The reason for that is because this person is not having ST segment depression in all those leads. So I'm going to erase the ink real quick and I will explain what I mean. The third step of my 6-step interpretational process is rhythm interpretation. If you look down here at the bottom in V1 right here, this is a rhythm strip that goes all the way across. This right here looks like to be a right bundle branch block. If you remember what I said in my first presentation, the temporal relationship tells me that this beat all the way over here to the right does not correlate with these beats over here, but it does correlate with these beats up here. And if I have an abnormal beat, I cannot use this beat to determine ischemia and infarction. So if I cross out all of these complexes here, that means I have to cross out all the complexes above it, because this is not actually telling me anything about my ischemia, or infarction. It will tell me what's going on with my rhythm. It may even tell me what's going on with my bundle branch blocks, but I cannot use those complexes to determine ischemia. Now let's look at this 12 lead again. Where is our ST segment depression? If you look at it now, it actually looks like that your ST segment depression is in V4, V5, V6, maybe a V3, and that's about it. So this person might be having an anterolateral wall subendocardial ischemia going on. What artery would that be affected would be the next question. Possibly the LAD. This might be the very early stages of an LAD occlusion. Reciprocal changes on the EKG. When I talk about reciprocal changes on the EKG, what I'm actually talking about is the mirror image of a problem. So, for example, in this case, we have this problem occurring way over here. This is what you're going to see with the leads that are directly looking at the problem. Well, what about these leads over here? They're technically going to see these electrical changes as well. But where you have elevation, you're going to have depression. Where you have depression, you may end up having elevation. So reciprocal changes can tell you a lot about the localization of particular heart attacks or ischemias or infarctions or whatever. The easy way to remember this is 2, 3, and AVF are reciprocal to 1 AVL and V6. Why is that? Because if you remember the hexaxial plane, down here, here, and here, this is 2, this is 3, this is AVF, this is going to be, lead 1, or V6, and lead 1. And up here is going to be AVL. So if you're having a problem over here, these are going to show reciprocal changes. On the flip side, if you're having a problem here on the heart, these are going to show reciprocal changes. Let me kind of explain to you using a 12 lead. Pretty ugly, huh? First thing I want to look at, like I said before, what is more dangerous, transmural or subendocardial? Transmural is. How do I determine transmural ischemia? Well, I look for all the ST segment elevation. So let's look for all the ST segment elevation. I have elevation in 2, 3, and AVF. So what exactly does this mean for me, for us? What I mean by that, and I'm going to try to draw this as best as I can. Here's a picture of the heart. We're going to say that this is the heart right here. 2 is over here. 3 is over here. And this is going to be AVF. We know that we're having transmural ischemia in 2, 3, and AVF. So I know that this area of the heart is currently being affected. But this 12 lead tells us so much more. Where do you see reciprocal changes or ST segment depression that is reciprocal to the inferior leads? Well, we do see lead 1 has depression, AVL has depression, V5 has depression, and V6 has depression. So I know that 1 AVL and V5 and V6 are all reciprocal to the inferior wall. Of the leads, 1 AVL, V5, and V6, which one has the worst looking ST segment depression? The answer would be AVL. Why? Look at the J point, and it is negatively deflected. Remember what I said about how bad the ST segment is, the ST depression is? Negatively deflected is the worst. Horizontally, not so much. Upward deflection, okay, whatever. The negative deflection is the worst, which tells me that reciprocal, AVL is going to look up here. So we're going to put AVL over here. Reciprocally, the AVL is going to look through the heart to this area right here. Now between 1, V5, and V6, which looks worse? V6 actually looks worse because V6 has more depression than V1 does. Interesting note about lead 1 and V6 is that V6 technically looks a little bit lower on the left lateral ventricle than lead 1. So they don't actually look at the exact same area of the heart. They look a little bit different. So V6 reciprocally looks right here. V1 reciprocally looks right here. Now all of a sudden, we're not just having an inferior wall MI anymore, are we? We're actually having a right lateral wall MI as well. There is some other ST segment depression on here that might be a little bit confusing. V2 and V3, this is considered reciprocal to the posterior wall. So we have this ST segment depression over here. That's a posterior wall MI that we're having as well. So not only are we having elevation in the inferior lead or the inferior wall as well as the right lateral wall, it looks like we might actually be having a posterior wall problem as well. Hopefully this helps explain the reciprocal changes on an EKG, but there is a problem. A lot of people have asked me in the past, how do you tell if a person is having subendocardial ischemia or transmural ischemia? Let me go back to this previous 12 lead. Some people will look at this and say, well, the person is having transmural ischemia over here. This is all transmural, but because this is all depressed, they're also having subendocardial ischemia? The answer is no. ST segment depression, which we normally consider subendocardial, but ST segment depression in the presence of ST segment elevation is a reciprocal change only. Just consider this a reciprocal change. Yes, it is possible. There could also be some microembolization going on. At this point, we shouldn't be worried about that. If we have ST segment elevation, anything that is depressed is a reciprocal change, not subendocardial ischemia. Hopefully now I've kind of explained the ischemia and infarctions in a way that will make a little bit more sense. You're always welcome to view these videos again to try to get more information out of them. Of course, you can always email me if there are any questions or anything. I'll be happy to try to explain this stuff because I do understand that this is difficult material. So let's go ahead and practice a little bit. I'm going to practice these 12 leads using the 6-step interpretational process. If you have not seen any of the other videos, then you're probably not going to understand quite what I'm talking about here, and you're welcome to go view all of those to kind of bring you up to speed a little bit. So let's go ahead and get started. Some of these 12 leads are probably going to look very similar because we've already looked at the ischemia and infarction stuff. So the first thing I want to look at is my general impression. My general impression is this is ugly. If you remember, the general impression is just a quick glance. It shouldn't take more than a half a second. What draws your eye? What draws your attention? In this case, the big ST segment elevation makes it ugly. My calibration is, you can look over here. This is my calibration marker, so I'm going to say my calibration is standard. First, I'm going to do my rhythm interpretation. My rhythm interpretation looks to be, that's a really wide PR interval there. So I'm going to say that this is a first degree heart block. What kind of rhythm is this? 300, 150, 100, 75, 60. So I'm going to say this is a sinus rhythm with a first degree heart block at, what did I say, 70? We'll say 70 beats per minute. I need to count that out. R wave progression. If we look at our R wave progression, normally we look V1 through V4, but you can also look V1 through V6. It should be primarily negative, transitioning to primarily positive, and the transition should occur somewhere between V3 and V4. Since V1 to V6 or V1 to V4 is negative to positive, I'm going to say my R wave progression is a good R wave progression. A quick look at my axis. Lead 1 looks like it's pointed up. It's supposed to be an up arrow. AVF might be biphasic, but it looks like it might be up. So I'm going to say that this is a normal axis, not a normal axis deviation, because if it's normal, it is not deviated. Bundle branch blocks. Well, it doesn't look like that I have anything wide, so I'm going to say that there's no bundle branch blocks. What about fascicular blocks? If I have a normal axis, I do not have a fascicular block. Now let's look at my atrial enlargement. Do I have any atrial enlargement? As I look over here in 1 and or 2 and or 3, it doesn't look like I have any humping or any peaking. So I'm going to say no atrial enlargement. Ventricular hypertrophies. I would have to count these, but I'm going to say that there is no for the precordial leads. And if you remember, AVL1 and AVF needs to be 11 millimeters of R wave, or 12 millimeters of R wave, or 20 millimeters of R wave, and I don't see that anywhere. So I'm going to say that there's no ventricular hypertrophies at all. Now let's look at my ST segment elevation. Oh, goody. I would have to have a piece of paper to really draw this out, but that might be some elevation in V1, V2, and definitely V3, V4, V5, and V6. So I'm going to say that this person has ST segment elevation V1 through V6, and it looks like 1 and AVL as well. 1 and AVL. Where do I have ST segment depression? It looks like I have the ST segment depression. If you look over here in 2, 3, and AVF, there is all kinds of ST segment depression over there. So I'm going to say this person has ST segment depression in 2, 3, and AVF. Do I have a pathological Q wave? Remember, a pathological Q wave is a Q wave that is at least 1/3 the height of the R wave. Do I have that right here? Yes, I do. Do I have that right here? Yes, I do. This, I'm not so sure. So I do have a pathological Q wave in V1 and V2. Now that I have all this information, how do I actually interpret this? Fortunately, we don't have any hypertrophies or R-wave issues, axis deviations, or bundle branch blocks, so my overall interpretation for my rhythm and my 12-lead interpretation is going to be sinus rhythm with a first-degree heart block at 70 beats a minute with, what does this tell me right here, this elevation? Anteroseptal lateral wall MI. Anteroseptal lateral wall MI. Do I have any depression? Yes, I do. I have depression in the inferior leads. Anteroseptal lateral wall with MI with reciprocal changes in the inferior leads. Do I have any pathological Q waves? Yes, I do. And whoops. You can either put the leads, or in this case we can just put in the septal, but you can put in pathological Q waves in V1 and V2. Oh, that's supposed to be a little 1, not a Roman numeral 1. With the pathological Q waves in V1 and V2. General impression, it looks a little bit ugly, but really, to tell you the truth, it looks like that this area right here is the area of concern, so I'm going to say ugly. Calibration, my calibration marker is standard, so rhythm interpretation looks to be a sinus rhythm, 300, 150, 175, so a sinus rhythm at 75 beats per minute. How does my R wave progression through my precordial leads look? It actually looks very good. My axis, if you look at 1 and AVF, it looks like it is a normal axis. Bundle branch or fascicular blocks. The QRS is not wide, so I do not have a bundle branch block. Normal axis, so I do not have a fascicular block. How about atrial enlargement? Look at leads 1 and or 2 and or 3. Look at the P wave. Do you see any peaking or humping of the P wave? And I do not. Ventricular hypertrophies. I'm going to look over here. This and V5 and lead 2 looks like the bigger ones. And I'm going to say no over there. Now, do we have 11 millimeters of R wave here? That's 5, 10, no. How about 12 millimeters over here? This looks like it starts on baseline, and that actually might be 12 millimeters. So it's possible it might be here. Possible 1. Left ventricular hypertrophy, and we don't have any right ventricular hypertrophy. No positive, no. The R wave needs to be bigger than the S wave, and it's not. Let's go ahead and look at our ST segment elevation. I already identified 2, 3 in AVF. It looks like we might have an elevation here in V5 and an elevation here in V6. So down here under ST segment elevation, I'm going to put 2, 3, AVF, V5, V6. Do I have any ST segment depression? It looks like I might have some depression in V1. I definitely have some depression down here in AVL. That might be depression there. Maybe some depression here in V2, but that doesn't tell me much of anything right now. So it looks like I have depression in, definitely in AVL. Do I have any pathological Q waves anywhere? Do I have any Q waves that look like that they're bigger than the R waves, or at least 1/3 the height of the R wave? To me, that looks like a pathological Q wave. This one, I'm not sure. I'd have to count that. If I had the piece of paper, I'd be able to do that a little bit easier. So definitely for sure, we have the pathological Q wave in lead 3. So how do we determine this, or how do we interpret this? Sinus rhythm at 75 beats a minute. And like I said, just start here and work your way across all of the interpretation. Sinus rhythm at 75 beats a minute with possible LVH in lead 1. Looks like we have an inferior lateral wall MI with reciprocal changes in AVL and a pathological Q, or a pathode Q, in lead 3. I've had people in the past ask me, do you really interpret a 12 lead like this when you're looking at a 12 lead? Do you really write down all of this stuff? And my answer to them every single time is absolutely. I write all of this stuff down when I write down my interpretation on a patient chart. And the reason I do that is because, God forbid, the 12 lead gets lost. And then I have to go sit in front of a board and justify my treatment plan. If I have a 12 lead that I can look at, then I'm going to say, oh, well, this is what I saw. But what happens if I don't have that 12 lead? I want to write down every single thing that I see, so that way if somebody says, well, it says here that there's possible LVH in lead 1. How do you determine LVH in lead 1? Well, I can tell you that. I can tell you everything I need to know about what I saw in that 12 lead just by writing down this interpretation. Let's look at our next 12 lead here. General impression, well, looks ugly, because I can see this ST segment elevation here was the first thing that drew my eye. Calibration, there are no calibration markers on here, but I think I cut them off when I cropped the picture, so Standard. Rhythm interpretation looks to be a sinus rhythm at what rate? 300, 150, 175. So another sinus rhythm at 75 beats per minute. R-wave progression from V1 through V4. It's transitioning very early, but it still looks to be a good R-wave progression. Axis, if you look at 1 in AVF, 1 is pointed up, but AVF is pointed down. So using the right together, left apart, I'm going to say that this person has a left axis deviation. Bundle branch blocks. There are no bundle branch blocks because the QRSs are not wide. Do I have a fascicular block? If I have a left axis deviation, I might have an anterior fascicular block. So what is the other criteria for an anterior fascicular block? Well, I need to have a Q1 and an R3. So do I have a Q1, R3? I do have a Q1, and do I have an R3? Actually, this is a QR. So I do have a small Q wave in lead 1 and a small R wave in lead 3. So I have that. Is my lead 1 pointed up, is 2 pointed down, and 3 pointed down. I can't really tell about lead 2 right here because it looks like it's actually biphasic. So I'm going to say that that's not up, down, and down. So I'm going to say that this is not a left anterior fascicular block. There might be some other criteria that might say yes it is, but the criteria that I've used in the past, this is not going to be a fascicular block, but it's headed in that direction. Do I have any atrial enlargement? If you look at leads 1 and or 2 and or 3, it doesn't look like there is any humping or any peaking, so I'm going to say no on the atrial enlargement. Ventricular, it looks like that V2 might have, I'd have to do the counting here, that looks to be about 11. That looks to be about 12, so it looks like it is just 1 millimeter further down than it is up. So there's no right ventricular hypertrophy, and there's no left ventricular hypertrophy either. ST segment elevation is going to be 2, 3 in AVF. Do we see any ST segment elevation anywhere else? You might have some. It's really hard to see my pen on this dark one, on this dark paper. So it looks like V5 and V6. Do I have any depression? I do in 1 and AVL. In 1 and AVL. So I'm going to say lead 1 and AVL. Is there a pathological Q wave? There's definitely a pathological Q wave. That's a pathological Q because it is greater than 1/3 the height of the R wave. That's a pathological Q, and that's a pathological Q. So I'm going to say, yes, there are pathological Q waves in 2, 3, and AVF. Do I see any more? And it doesn't look like there are any more. So how do we interpret this? Sinus rhythm at 75 beats a minute with a left axis deviation, inferior lateral wall, MI, with reciprocal changes in 1 in AVL. So you can say 1 in AVL, or you can reciprocal changes in 1 in AVL, or you can put lateral leads. This might be confusing because how can you have a lateral wall MI with a lateral reciprocal change? So sometimes you can just put the specifics, or sometimes you can just list out the leads themselves. Do I have any pathological Q waves? In the inferior leads, or 2, 3, and AVF, which of course are the inferior leads. So this person is having a pretty bad heart attack right now. The last 12 lead I want to look at here is this one right here, and I actually left the interpretation on it just for fun, but I want to go ahead and walk through the step-by-step interpretation process. So general impression, obviously just by glancing at it, it looks fast. That's what it looks like, is it looks fast. Calibration, well, we have our calibration marker over here, or you can look down here, 5 millimeters per second, 1 time, which is standard size. You can put standard. Rhythm interpretation, here's the interesting part. The monitor interpreted my 12 lead as a sinus tachycardia. I'm going to disagree with that because my heart rate is 178 beats a minute and I do not see clear P waves. Therefore, I'm going to consider this as an AV nodal reentry tachycardia. And there's all kinds of different rhythms, supraventricular rhythms, but I'm going to say that this is an AV nodal reentry tachycardia, and I'm going to say it's at 180 beats per minute. Why? Because they give me the rhythm at the top, or they give me the rate at the top. How is my R wave progression through my precordial leads? Technically, even though the sucker's at 180 beats a minute, it's a good R wave progression. How about my axis? Well, there's two things I can do. I can either look at lead 1 and look at lead AVF, or this is what I like to do. Look at your QRS right here. That middle number, 33 degrees, tells me that it's a normal axis. Here's my thing. Bundle branch or fascicular blocks? Well, the QRS is not wide, so I know there's no bundle branch blocks. How about fascicular blocks? There is a normal axis, so I cannot have a fascicular block. Can I determine atrial enlargement? No, there's no P waves, so I can't determine that. How about ventricular hypertrophies? I could determine that. So let's look over here at V5 or V6. V5 is bigger, so I'm going to say 5, 10, 11, 12. Here's my baseline. How far down do I go on V2? 5, 10, 15. So that is not going to be greater than 35. So I'm not going to have any left ventricular hypertrophy, and the QRSs are both pointed down in V1, which means I don't have any right ventricular hypertrophy, so I have no ventricular hypertrophies. Now, do I have any ST segment elevation? And as I look at each one of these leads here, I don't see any elevation here, none here, no. Well, no, I don't think so. None here, no elevation, no elevation, no elevation in V2, no in V3. I don't see elevation anywhere, but what I do see a lot of is ST segment depression. I do see a lot of that. Where is our ST segment depression? How about in lead 1, 2, AVL? It's going to be everywhere. So lead 1, 2, AVL, maybe V2. How about, looks like V3, V4. I guess I could have just put V2 through V6 and not put all of that stuff. Those are the biggies. Looks like maybe some I got AVL in lead 1. So it looks like that it's everywhere. Do you see any pathological Q waves? I don't see any pathological Q waves on here, so I'm going to say no to the pathological Q waves. Now, when I look at this, it looks like that I'm having some global, almost, subendocardial ischemia. The problem here is that this subendocardial ischemia is not coming because of a clot. This subendocardial ischemia is rate-related. So my interpretation is going to be AV nodal reentry tachycardia at 180 beats a minute with rate-related subendocardial ischemia. I hope you enjoyed the presentation. That's all of the 12 leads I have, unfortunately, at this time. So if you have any questions, please feel free to email me, and feel free to use this information as best as you can to try to start interpreting 12 leads or start looking at 12 leads. Thank you.